Hi, everyone. Welcome to another episode of Dr. Gilbert Hosts. Today, we're going to be discussing a very important topic that you might not think of when you think of Parkinson's disease, and that is dental changes associated with Parkinson's disease. You may not be aware how much your mouth and teeth can be affected by this condition. So we're glad you're here to learn from our expert. And our guest today is Dr. Louis Siegelman. He is a dentist who has focused his practice on patients who have particular difficulties with the dentist, and these include movement disorders and cognitive decline. So Dr. Siegelman will be giving us a brief introduction, and then we'll be answering your questions, so get those ready. It is now my pleasure to formally introduce you to Dr. Siegelman. Dr. Louis Siegelman is a board-certified dental anesthesiologist in New York City. He's a graduate of Queens College, after which he completed dental training at NYU College of Dentistry, a residency in general practice of dentistry at Jacobi Hospital, and a residency in dental anesthesiology at Long Island Jewish Medical Center. He's currently on the faculty at NYU College of Dentistry and NYU Langone Brooklyn, and maintains a private practice in Midtown Manhattan, focused on patients who have difficulty going to the dentist because of special medical needs. And these include panic and anxiety issues, PTSD, difficulties with local anesthesia, a sensitive gag, as well as movement disorders, dementia, and more. A very special dentist. Welcome, Dr. Siegelman. We're so happy you're here with us today.
Thank you so much, Dr. Gilbert, and a special thanks to the APDA for having me on. And I really look forward to discussing this with you back and forth, and thank you for all the people tuning in. I think the most important thing is oral health, which is a tremendous factor in neurodegenerative diseases. And I want to hear some comments later from Dr. Gilbert on oral bacteria that may be involved in neurodegenerative issues. But, really it comes down to being prepared, taking care of yourself beforehand, optimizing your dental care, optimizing your dental health, maintaining that with nutrition and good home care, and then the help of all your the support people that you may need later on as in the Parkinson's process. So I have a very brief slide presentation, and I hope to get into these details a little bit further and to hear from Dr. Gilbert on her thoughts. So let's click into our slide presentation. And here we go. So really, it's about this pre-care. So planning for the future, making good decisions. What is really necessary? What should be done now? Like, how could we make our good decisions? Certain things in dentistry can be elective. Like, do we want to have veneers? Do we want to have aesthetic treatment? Maybe some of these teeth that are maybe marginal, maybe we shouldn't bother saving them. Maybe later on, they're going to be difficult to clean, difficult for a caregiver to help clean, and maybe those teeth should be left off. What is a functional dentition? How can we keep you healthy in terms of your gums? And the gums are a great reservoir for bacteria. So, and there's really no other place in the body where bacteria that we harbor, that we give them a place to live in our body, and they can get so easily into the bloodstream. And once they're in the bloodstream, they affect our entire body, our circulatory system, our vital organs, our brain, our heart, our lungs, kidneys. But we really want to keep these pathogenic bacteria out of our systems. And so we really want to maintain our periodontal health. So we really want to get a very, very good exam early on in the process and make good decisions with our dentist when it's easy to get care, when it's easy to keep appointments, when tremors are not such a big factor and we respond very well to medication. That's really the time to clean things up. If you've been putting off dental care, clean it up early and make good practical decisions that'll help you going forward. So, and we want our dentition to be very maintainable. So we don't want to build things that may be very difficult for us to maintain later on. Maybe there's certain things that just require a lot of manual dexterity to clean, to insert, to take out. So we have to make sure that whatever we're having our dentist make for us is something that we can handle, our caregivers could handle, and our caregivers have instructions so that the dentist could be part of the team training those people who are taking care of you to help you with any dental prosthesis, a denture, something that comes in and out, how to clean. So those are really important factors. But a lot of dental disease is self-inflicted. So people that really brush and floss and they don't have a lot of acids and sugars in their diet, those people don't tend to get a lot of dental disease. So just by interviewing somebody, if I say, what do you drink? What are your habits? And I listen to them, I can really, before I even look, I have a very good idea of what their teeth are going to look like, how much at sugary beverages. And a lot of times it's with really the best of intentions. And I've seen nutritionists design diet plans where they go for 0-calorie beverages, which seem great. 0 calories, we're not going to gain weight from that. No sugar, that sounds great. But a lot of these beverages, for taste, there's things like citric acid in them, phosphoric acid, malic acid. And you'll see the greater the concentration that is in that beverage, the earlier it's going to be. So if maybe it's like, let's say the third or the fourth or the fifth thing mentioned in the ingredients, maybe there's not so much of it. But if it's right up there behind water, citric acid, water, phosphoric acid, that's going to be very, very cavity producing, cavity provoking. So that really should be avoided. So it really comes down to often what's in your refrigerator. And what are really good beverages? Water, of course, is excellent. Fresh brewed things that are made in the factory tend to be hyped up. There's more sugar added. There's more flavoring added. There's more artificial chemicals. It's becomes ultra processed foods, which are not so great for us. So homemade things, fresh brewed tea. I usually recommend not the black tea, because if I'm telling somebody to drink something, I don't want them to have an ill effect. And sometimes black tea can produce kidney stones. So usually green tea, white tea, could be decaf. But that's fresh brewed at home, and that's going to be much healthier. That's very different from ultra processed teas. If you go into the supermarket and you buy a little bottle of tea, I don't want to mention names, but there's probably a lot of ingredients in there that are really not great for us. So fresh brewed, and you could make a nice pitcher of that, leave that in the refrigerator, and you could flavor it with something like slices of cucumber, a little cinnamon, natural things like that. Try to avoid, even though honey is a natural thing, try to avoid things that are sugary. And a very interesting thing is that it's not only what's in there, but believe it or not, it's how long it actually takes us to drink that. So some people will come in and they'll say, I only have 1 can of soda. It takes me 2 days to finish that 1 can of soda. And they're very proud that they're not drinking so much soda. But when you're sipping it, when it's a sipping beverage, and you're just having a sip of that, and it bathes the teeth, it washes over the teeth, the acid, the sugar, and it stays there. And then it takes the saliva maybe about a half hour, 45 minutes for that to be restored. The saliva is not water, it's really a mineral bath, and it will restore your teeth. It'll remineralize your teeth. Now, if you have good salivary flow, that'll take maybe about a half hour. But if you're on medications and your disease process is a little more advanced, you may not have as much saliva, and it's going to take much longer for your teeth to remineralize. So you could coat your teeth with sugar and acid, but it's going to take much longer to repair that. So now if you're sipping that all day, there may be many hours where your teeth are exposed, to that sugar and acid, and it's not going to be good for them. They're going to get those people will get tooth decay, particularly if there's recession, which is kind of a natural thing that happens in life as we get older. Our gums recede a little bit, our foreheads get a little bit bigger, and our gums recede a little bit. And that exposes the root surfaces. And the root surfaces are not protected by this enamel. So enamel, like enamel paints, the enamel covering, that protects the teeth. But it ends. It doesn't go all the way to the tip of the root. It ends. It's really the part that we see, like when we're 16, when we're 25, we're only looking at enamel. Later on, we start to see a little dark around the edge of the tooth, and that's the darker root surface. And that usually won't decay early in our lives. But as we get into our 50s and our 60s, particularly if there's a lot of exposure to acid and sugar, those areas will start to decay. They don't have the enamel protection. So we need to really modify what's in our refrigerator. And we want to make sure that our caregivers have the right things in our refrigerators. So, and the right toothpaste is very important too. It should be a fluoride-containing toothpaste. And there's really a way to get the most out of your toothpaste. So almost everyone, by instinct, will brush their teeth and rinse their mouth out with some water, some mouth rinse, something. So we brush and we rinse. But that's really not the best way to do things. So the best way to do things is to rinse first. Rinse before anything else. Get all those little particles of granola and nuts and all the things we've eaten all day. Rinse and rinse and rinse in the sink until you do not see anything else coming out. We rinsed away all that granola. We got it all out. Then brush your teeth. Brush your teeth and brush all the surfaces. Brush behind the teeth. Brush underneath the tongue. Brush the inside of the teeth, the outside of the teeth. Brush everywhere very, very, very thoroughly. But do not rinse that toothpaste away, because that toothpaste has goodies in it. It has fluoride in it, and it has things that prevent tooth decay and remineralizers. If you rinse it away, it goes down the sink. What good is it? So you want to leave that little patina of toothpaste on your teeth. That is when you floss. Now you're going to floss that little patina of toothpaste. You're going to get that toothpaste down underneath the gums with flossing. You're going to get it in between where cavities form, where tooth decay forms. Now you're really getting that toothpaste where you need it to go. And you're going to floss out all these areas. And what you're going to do is you're going to disturb the bacteria. So they're not going to just fester there, because if you leave the bacteria to fester, they double and they double and they double. And that's when they're going to cause problems. They're going to cause inflammation of your gums. And that's when they're able to get into your circulatory system. So we have to plan things out. And I often think of different models of healthcare. So there's a surgical model of healthcare, which is usually how dentists work. Oh my God, your tooth has a chip. It's got a little hole in it. We have to fix that. We have to cover that. So dentists work usually on the surgical model of care. We're oriented toward intervention. But there's another model of care. What about people who have diabetes or hypertension? We're not just going to cure their hypertension. We're not just going to cure their diabetes. We have to manage that situation. So it becomes a medical management situation. So when we have somebody with Parkinson's disease, we have to weigh the risks, depending on where they are in the disease process. We have to weigh whether or not the intervention is going to be worthwhile for that patient. Maybe it's a front tooth. And we might say, I know my husband would never have wanted to walk around with a damaged front tooth like that. I know them. I know that's their wishes. And so then maybe the caregiver will support getting that repaired. But we have to weigh what's important for the patient and what's important for us. And we have to look at the surgical model versus management. So later in the disease process, my questions really are, is the patient in pain? Do they have infection? Are they eating? Are they complaining? Are their teeth a problem for them? And so later in the disease process, I may actually leave things that Otherwise, I might well take care of. But there may just be at that point just not so much benefit to the patient, and maybe the patient is tolerating this very well. So if we're going to think of intervention, we want to make sure we do that early when it's very easy to get things done, when we don't have to even think about using anesthesia or sedation for our dental care. But later on, if sedation becomes an option because there's the dementia may become a factor, and the patient's ability to cooperate may become a factor, maybe it's not worth the risk or the involvement to the patient to do that. So we have to exercise good judgment, balance our risks and benefits of dental care. And at a certain point, it may even be hospital versus an office environment. So if the patient has other medical issues, if there's cardiac issues, if they're very heavy and they can't really stand up or be transferred into the dental chair, these become factors. So it really becomes a lot of coordination and communication with the caregiving team, with the patient, and with the dentist to see the capabilities of the facility where they're being treated and what kind of care they really should be having at this time. But the more we could prevent, the more we could take care of things up front or early on, upstream, the better we're going to be. So we want to optimize that dental appointment. So we have to really understand the needs of the patient. Is there a lot of anxiety about dental visits, which is very common, particularly, dentistry, we all know, has come light years and it's so much more comfortable. And there's so many high-tech options for comfortable and efficient care. But maybe this person is a little bit older. Maybe they grew up in an age when dental care wasn't always exactly like that, and they didn't have a lot of availability for dental care. So they may have a lot of anxiety about dental visits, or maybe a very sensitive gag reflex. There are some people, believe it or not, where the local anesthetic doesn't really work so well for them. The dentist gives the local anesthetic, the numbing medicine, and the patient says, I still feel that. And that can happen. That's probably about 5% of people. So we need to know all these things. We need to really understand the dentist, from the dentist's perspective, who this human being is and what kind of care they really need. Are they interested in cosmetics? I've had patients, again, where the caregiver, maybe later on in the disease process, and it's hard for the patient to really communicate what their desires are, but the caregiver, the wife or the husband, really understands them and knows she would never have wanted to be missing a front tooth. She really would have wanted this kind of care. Often the patients really know how to time their medication the best so they could be optimized. They could optimize themselves for the dental visit. And maybe the tremors are very controllable early on. Maybe we reach a point where the medications are less effective and tremors are more of an issue, and therefore sedation becomes more necessary, especially if dementia is in the picture. And if we're picking a dentist and we're deciding where should we take our loved one, we need that to be an accessible environment. So all these things become factors. Fluoride containing toothpaste. Don't take the patient off fluoride. There's a big thing out there about fluoride and eliminating fluoride from the water. But I could tell you firsthand, when patients take themselves off fluoride, they get a lot of cavities. And if you have Parkinson's, you're really not in a position to say, yeah, fine, I'll get cavities, I'll get the work done. If I get a cavity, I'll get the work done. It becomes more and more difficult. And so a high fluoride toothpaste, a prescription toothpaste, becomes more important. There's different technologies in toothpaste. And when a toothpaste says it remineralizes, it strengthens enamel, that works. So there's a variety of medications and compounds that can help teeth remineralize. There's calcium triphosphate, there's casein phosphopeptides, there's all kinds of remineralizers. So when the tube says it remineralizes, It probably does. Although I would stick to a major brand. So because then at least you know what you're getting. And I think there's safety in sticking to a major brand. If the tube says it whitens, that may mean nothing. Your tooth will be whiter if it doesn't have the leaf of spinach, on the front of the tooth. It really doesn't mean anything. If it says bleaching, bleaching is really different than whitening. So bleaching is a technology that works, but generally a toothpaste won't really do that because the toothpaste is not on the teeth long enough in high enough concentration for it really to bleach the teeth. So that's really like a special product. Some of those home products work. Some don't really work really well. But professionally, that's really the best way. But that might be just something that's not necessary or not desired. It may be extra visits to the dentist just to whiten your teeth. May not really be practical. As we discussed, it's rinse first, brush, then floss. Something that's very, very helpful. So when you're brushing someone else's teeth, it's actually a very, very difficult thing to do. And I find that patients later in the Parkinson's process, they don't swallow their food. So there'll be food that's really left there, much more so than ordinarily. Usually if we have some granola or something stuck, next to our teeth, we'll make every effort to get that out. We'll stick our tongue there, our finger there. We'll rinse, we'll get it out. But patients who may have dementia, they don't really do that. They just let it sit there. And so if you're, and patients with dementia, they start to become a little resistant to somebody brushing their teeth. They just don't want it. And if you're brushing, it becomes very difficult. You may just be moving the food material around and not really getting it out. So one of the most helpful things, and maybe we could put this in the show notes, and this is one place where I think I would mention some units. So there are units, they're home suction units made by Schuko or DeVilbiss. And these are home suction units. They're really easy to use. And it's just as if a vacuum cleaner is much better to clean your carpets and floors than a broom or getting on your hands and knees. Being able to vacuum stuff that's in the teeth and just get it out of there. Sorry for the sound effects, but just get stuff out of the mouth. It's fast, it's easy, it's safe. It's safe to do that. And so there are these home suction units. And if you order this from a surgical supply store, you always order all the disposables. So there are disposables. So there's usually a canister and tubing and then the suction tip. So, but you could reuse that. So you could use it as long as it doesn't get yucky looking, you could keep reusing it. And what I would recommend is use it on the patient, on the person, and just suction out everything you can. And that does not replace the application of the toothpaste, because remember, the application of the toothpaste that has fluoride in it. So you do want to suction, but you want to brush even if it's only to apply the fluoride in the toothpaste. And then what you could do with the suction unit, you could just run a little mouthwash through it, a little water through it, and just clean out the tubing. And this way it's disposable tubing. In a hospital, that would be single-use stuff. But for home care purposes, you can reuse that until it starts to look a little yucky, and then it's disposable. Just get another set of tubing and a canister. And pretty much any surgical supply store will have that. And maybe we could put it in the show notes. DeVilbiss, they make a variety of units, and Schuko makes a variety of units. And when we're providing care for someone, the more force we use, the rougher we are, the more they're likely to resist. So we want to be able to provide this home care in a very comfortable way for this person, and we want them to accept that care and not reject it. So we really need to use a very gentle approach, so we're not later creating more resistance. And you want to really encourage the patient to swallow their food. encourage them to swallow their food so that everything becomes self-cleaning. When do you seek professional care? So I would continue 3-month recalls as long as possible, just for hygiene, and indications, for professional help later on might be not eating, pain, swelling. Swelling always requires immediate attention. Swelling is infection. So the most important thing you could do for a patient that is swollen is get them early antibiotics. And that may be at a certain point, that may be the best treatment, where maybe anesthesia or sedation for a person who's at some advanced stage, maybe it's just too much of a risk. But periodic antibiotics may be the answer at a certain point in time, so that somebody could get care. They won't have infection, they won't have a serious infection, they won't have pain, they could eat, but it avoids intervention. But these decisions all have to be made. I always really try to establish a good rapport, and I want to know that the people that I'm taking care of, that they really understand what the process is and how we can best help the patient, and what to expect. And I think that's our whole that's the whole show. Happy for any comments or thoughts that you guys may have.
Thanks so much. That was fantastic information. And as you were speaking, we've had questions come in fast and furious. So we'll try to get to as many as we can. And I apologize to the audience if we don't get to
Love
all
questions.
of them. Excellent. So our first one, I'm going to bring together a question from Carol, Gail, and Dale. They all ask a question about you mentioned that the suction, that seems to be, an excellent tip. I didn't know about that at all. That sounds like a great
thing. That's a real winner, because it's so much easier for the patients, and it's so much easier for the caregivers. And Lord knows it's hard. It's hard for everybody. And no one wants to be ill. No one wants to need help. We all want to be healthy, and we didn't ask for these situations. And so the easier we can make it for everybody, the better.
Yeah. So some of the equipment that some of the people in the audience have been asking about, we'd love your opinion on. So Dale asks about a water pick, water flossers, and electric flossers. Are those useful tools for somebody who's having trouble keeping their mouth clean?
So it depends. There's a lot of water to swallow, and I don't want anybody to aspirate. So if there's difficulty swallowing, I don't want the person to be aspirating liquid, even just water, on a daily basis, because it's going to predispose them to pulmonary complications, respiratory complications. They may start to cough on that. It has to be done very carefully. And it depends on the type of bridge work, the prostheses that people have. So, like if people have implants and there's a lot of hardware there, but they're not really shaped like natural teeth, then a water pick can be very helpful to get under there. If they have natural teeth that are easily brushable, the brush and floss is probably the best thing. And if I'm going to recommend a water pick, it's usually at that rinsing phase. Remember, it's rinse, brush, floss. So I would recommend it at that early phase. But because you wouldn't want to wash away the toothpaste, because the toothpaste has the fluoride, and that's gonna be preventive. That's part of the medical management. So if you're going to use it as the rinse part of the rinse, brush, floss. But be mindful, if the person's going to cough on that, or you're afraid they're going to aspirate, if they're not swallowing well, it could be a little bit of a risk to that.
Yeah, very good point. Another person, Gina, asks about an electric toothbrush versus a manual toothbrush. Do you recommend electric toothbrush?
Yes, so I definitely recommend an electric toothbrush. My house, I live in an old house, and I don't have like a lot of electric stuff, like a lot of outlets and cabinetry in my bathroom. So I like the Oral-B makes like, they're like $7. It's like an electric toothbrush that's disposable. So I like that one, because I hate having to, I ordered it, but that's a different toothbrush. They discontinued that toothbrush. I spent $120 on the toothbrush. Then it only lasted 3 months. So I like these $7 things. Throw it out when you're done with it. We're saving the planet maybe in a little bit of a different way, but that's usually what I use. But definitely an electric is going to be much more effective. It's got a lot more movement in it than our arm. So it's going to be better.
All right, fantastic. So that's a great answer, Regina. Roberta asked a question. Now, you talked a little bit about tremor and how people can sometimes time their medications to make their tremor less when they're at the dentist. But if that isn't working for a patient, and Roberta says that her tremor gets worse when she goes to the dentist because of stress, and we do see that, what kind of options do you have in terms of anesthesia? She says light gas. Is that an option?
Yeah, so nitrous oxide is a great option if that's what works for you. So if it's really anxiety, so nitrous oxide is actually a very good pain reliever. And it is like a little disorienting and distracting. So some people are very comfortable with being a little disoriented and they could go with the flow. Other people are not very comfortable at all being distracted and disoriented and not feeling in full control. And nitrous oxide can also promote some nausea. So it's a good agent, especially when somebody says, nitrous oxide, doc, do you have that gas? It's the only thing that works for me. So if somebody's going to say that to me, that's going to be preferred. But if they're not going to say that to me, my first line will usually be something in that Xanax family, alprazolam. So that could be that and related compounds. So usually that would be the alprazolam, the Xanax, or midazolam. So midazolam, people usually may know the name Versed, and that's the brand name. But there's actually an oral elixir that is oral midazolam, oral Versed. And that could be very helpful. So there's less skill needed. You don't have to start an IV. It's not really a deep anesthetic. So that could be, so the progression might be nitrous oxide, sweet air, laughing gas, in combination with alprazolam. And then if somebody needs something a little more, then oral midazolam, oral Versed may be indicated. And that could be very effective in reducing anxiety, and the tremor is definitely potentiated by the anxiety. So that's good. If not, we can use IV sedation, and usually that is titrated to effect so that it's just enough to help them be unaware or help them be more cooperative. And so that could be very effective. And that usually is a slam dunk. And that will almost always, in Parkinson's patients, eliminate the tremor, even at light levels of sedation. But there was something that you and I discussed, Dr. Gilbert, that I found very interesting. I had a patient with essential tremor. And even at deeper levels of sedation, I could never really abolish her tremor. But when I added ketamine to her sedative regimen, it abolished it magically. So I thought that was very interesting. When I went to look it up, I didn't see any references in terms of essential tremor, which is that's your only issue. You don't have Parkinson's or neurodegenerative issues. You just have this tremor, sometimes from an early age, essential tremor. And so I found no information on ketamine and essential tremor, but I saw it in reference to Parkinson's. I saw research and case reports in reference to Parkinson's. So that's another thing. But you need a dental anesthesiologist, you need a medical anesthesiologist to provide that kind of care. But I think, at a general dentist or a physician could certainly prescribe Xanax for you, which will probably be very good. And many, if not most, dental offices do offer nitrous oxide. So that's also relatively abundant.
Fantastic. Great information for our audience. Thank you. We have a few people who have asked about dry mouth. Now, you talked about how dry mouth can be associated with Parkinson's disease from medications sometimes, and that can exacerbate tooth decay if somebody has a dry mouth. Do you have solutions for dry mouth that can be implemented?
Yeah. So stay well hydrated, of course, number one. I would also sleep with my best recommendation, because I don't have such great recommendations on this issue, but my best recommendation is really like a steam or warm mist vaporizer. So what happens is it's not just their mouth, it's their whole airway that gets dried out. And depending on where they live, the time of year, what kind of heating system they have in their house, that could be a factor. But keeping your airway moist really helps people breathe easily. And I find, like when you have a terrible cold, and you're so happy when you get into the shower because there's so much steam and you could breathe. This is great. So a steam vaporizer is very, very good for that. Now that I ran out of good suggestions for this, and my next level of suggestions, there are dry mouth products. Now there's one company I really like, and that's ACT, and they have dry mouth lozenges. And patients have said to me, that's the only thing that works for me. There's a lot of companies that make products like that. Some people will say, none of these have worked on me. Other people will find a product. So even with lots of things like toothbrushes and flossers and dry mouth products, go into that aisle at your pharmacy and buy some stuff. And try 3 or 4 things. Try 3 or 4 different types of flossers, or little things that go in between, little tiny brushes to get in between your teeth. Buy 3 or 4 or 5 things for like $7 a pop, and probably your local pharmacy will take it back if you tell them wasn't good. So you're probably not going to be out that much. But it's amazing. Some of them feel like they're unusable. Some of these like floss things, they feel like, even in my hands, I'm a dentist, and it feels like they're unusable. Who's using this? Because it's so awkward, or it breaks in 3 seconds on one tooth. So try different things out. But I would recommend, if I'm going to make one recommendation, it would be the ACT dry mouth lozenges.
Fantastic. Thanks for that tip.
Yeah.
We had a couple of people ask about clenching of teeth. So BN asks, is clenching teeth a symptom of Parkinson's? And Giuseppe asks that about biting the inside of his mouth. Do you find that that's something that you see in people with Parkinson's? Do they complain about that? And do you have any suggestions about sort of abnormal movements of the mouth?
Yeah, so this is a huge issue, and I don't really have great answers for this one either. Some people have said Botox, but I think that that's something you would really need somebody who is super skilled, specifically in this issue, with a lot of experience, because I would not. It's a terrible thing if the patient cannot swallow food. And that becomes an issue of a whole other order of magnitude. So Botox is maybe a possibility. Mouth guards are not really a possibility, because they're going to be broken. There's going to be pieces in the mouth that you can't retrieve. Somebody could aspirate that, swallow it. Not a good idea. Sometimes with caregivers, they will clench while somebody's trying to brush their teeth or clean their mouth. And I think like a towel may be like the softest, best thing to put on the opposite side, and work on one side, switch the towel, and then work on the other side. So, but it's really a big problem. People wear down teeth, break teeth, and it's a huge issue. I don't really have an answer for that. There really is not a good answer for that.
So that's a really interesting point. And I wonder if sometimes, from a movement disorder perspective, the clenching could potentially be a dyskinesia, an abnormal movement sometimes
Yes.
from levodopa. So
Yes.
maybe
Yes.
adjusting medications could be
Thank you.
something that people may consider talking with their doctor about. It may not work, and you're right about how much it's an issue for people with Parkinson's.
Yeah.
And
Well, thank you for that. I didn't consider that about the medications, the dyskinetic
Yeah.
effect.
Certainly possible, but not always the
Yeah.
answer.
I think it could also be. I'm sorry to interrupt,
No,
but I think it could also be a symptom of pain or discomfort. That it's like a way to scratch the itch, or to try to address the pain.
Yeah, no, absolutely. So we had another question um, that Gail asks, and you addressed this a little bit, but I think many people would be interested in a little bit more about this. Bottom line, are Parkinson's disease patients more susceptible to decay than somebody without Parkinson's?
I think it's consistent with other neurodegenerative diseases. Dry mouth, medications, secondary to medication, decreased salivary flow, not swallowing. So I think I would just lump the Parkinsonian patients in with other neurodegenerative processes.
Okay, got it. Um, so somebody asks, what does ACT stand for, and how do I find it on the web? Can you
Oh,
just
okay. It's just
clarify?
ACT. It's the name of the company, and I really trust that company. Like they were one of the first to come out with a fluoride-containing mouth rinse. That was so great. Like you rinse your mouth out, and they also were the first or one of the first to come out with alcohol-free. And alcohol is a risk factor for oral cancer. So the mouth rinses, I won't name them, but the ones that really burn, they contain so much alcohol, and that's why they burn, and it's a risk factor for oral cancer. And I think the literature is a little equivocal about that, but nevertheless, I think it's a risk factor. And so, fluoride containing, alcohol free, dry mouth formula, ACT has all that, and they were among the first to come out with that stuff. So I really think they're a very forward-thinking company, and I have no affiliation with them. So it's a heartfelt recommendation.
Fantastic. Um, so we are very, very close to the end of our time, amazingly. That really ran fast. So we're going to maybe be able to answer one or two more questions. So we have a question from Jeff. I don't know if there's a great answer to this one either, but it's a very interesting question, and I'm sure one that many people deal with. Is my spouse sleeps with their mouth open, and that exacerbates the dry mouth. Any suggestions on how to keep the mouth closed during sleep?
Yeah, so there is a movement where people tape their mouth closed, but I would not do that, especially for somebody who may not be able to really communicate how well they're breathing. I would not do that involuntarily for or to someone. But I think the steam vaporizer may really help them.
Yeah, no, that was a great solution. It
Yeah.
doesn't matter if your mouth is open if you have
Yeah,
nice
Vicks makes it.
air.
Vicks makes, if I can mention Vicks, I don't have any affiliation with them also, but they make a very good one.
Very good.
And
Okay.
they run
So
like, around $30, $40, so they're not too expensive.
excellent. So you mentioned, just to finish up our last question, we're going to talk for 1 minute about the microbiome in the mouth.
Mhm.
Um, is there an association between a good microbiome in the mouth and helping tooth decay? What's the thoughts on that in today's world of dentistry?
Yes, there definitely is. It's something that we don't really know enough about, but yes, the healthy microbiome. But definitely, there are oral DNA. There's a company called Oral DNA, and we could swab the inside of somebody's mouth, or get a saliva sample and get an analysis of the bacteria that are present. And some of them definitely are cavity provoking. Some of them are cause gum disease. Some of them are transmissible, meaning that family members could get that gum disease. But I was going to bring this up, and I wanted your comments about oral pathogens that are associated with neurodegenerative issues. And I know that I think it's Pseudomonas gingivalis is associated with neurodegenerative. But I was listening to a New York Presbyterian neurologist, and she said that there are three that she knew of. I don't know how many you know of, but I think it's a growing awareness that this reservoir of bacteria that we tolerate in our mouths, and they could be very asymptomatic, but they easily get into our circulatory system. And if you have any comments about like an infectious disease etiology for neurodegenerative issues, viruses, herpetic viruses, oral bacteria, other bacteria, as the underlying causative agent.
So this is a huge topic that we probably should dedicate an entire Dr. Gilbert host to. So the last minute.
You could tease
I
us.
think exactly, a teaser for next time. I think there's a lot more that's been studied about the lower gut than the mouth in terms of the bacteria that's in the gut that may be sort of Parkinson specific. And there are many labs across the world really that have studied what does the gut bacteria of someone with Parkinson's look like versus somebody without, and are there differences? And people have studied this with lots of different diseases. And different labs actually come up with different sort of cohorts of bacteria. There isn't really like this, clear, this is the bacteria analysis of somebody with Parkinson's. There are some themes that are repeated in the different labs, but it's certainly something that requires more investigation. But there is this general feeling that the gut bacteria of different diseases may be different, and that may be either responsible cause or effect, that causes the disease or is the effect of the disease. And that's also a little bit unclear. There's this concept that maybe there's a pathogen that gets into the gut and sort of starts the process of alpha-synuclein abnormally aggregating. So alpha-synuclein is the protein in Parkinson's that takes on this abnormal structure and then gloms together and causes an abnormality in the nerves that line the gut and can cause degeneration of nerves in the gut. And that by processes that have not been well worked out may start involving the brain. Perhaps the vagus nerve is involved. There's a tremendous amount of speculation about such issues, and perhaps a pathogen is what starts that whole abnormal process. So a lot of theories, a lot of interesting ideas, and a lot of labs working on this, and we don't have all the answers. So that's kind of a very short way of describing what happens in the gut. Does a similar thing happen in the mouth? Probably. I mean, there are lots of bacteria in the mouth as well. So I think there's a lot there and a lot we don't know. So to be continued would be what I would say.
But, it's long been known that people need to take antibiotics if they have a heart valve issue, because it's very easy for these bacteria to get introduced into the bloodstream just by brushing, just by having a professional cleaning. So I think that, it's direct access right into the bloodstream. Absolutely.
It's a very easy way. So the mouth is exactly much easier to get into the bloodstream than the gut. So that is something that we have been, as you said, aware of for a really long time. So super interesting. Lots more to say about the mouth, but we are at the end of our time. So I wanted to thank you, Dr. Siegelman, for all that amazing information. And I wanted to thank our audience for listening and asking all our questions. The questions that we did not get to answer, we'll try to collate those questions and come up with some answers for you and put it on our website. We try to do that at the end of our broadcast when we have lots of information that we couldn't get to. So stay tuned for that. So again, I want to thank Dr. Siegelman for all that fantastic information. And if you knew someone who missed today's program, if you joined late, if you'd like to watch again, this recording, basically when this is over, will be available on our YouTube channel. And when you're there, don't forget to subscribe so that you can watch those new videos and the live broadcasts. And for additional information and resources, please visit our website at apdaparkinson.org. And I'd love you to be aware of our next Dr. Gilbert hosts, which will take place on Thursday, December 12th at 1 p.m. Eastern Standard Time. We'll be discussing the unique issues of women and Parkinson's. So we hope to see you then. Be sure to stick around for a few final messages. Before I go, I want to thank you again for joining us today. We hope to see you on another APDA program. Have a great afternoon or evening. Have a great day. Bye-bye.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.